I'm Lucy Nalpathanchel. The Where We Live team will continue talking about COVID-19 and its impact on our state. But today, we want to acknowledge those who may be struggling with substance abuse. This hour, we're rebroadcasting a recent conversation on the impact of alcohol on public health. As always, thanks for listening. This is Where We Live from Connecticut Public Radio. I'm Lucy Nalpathanchel. 100 years ago this year, Prohibition went into effect, putting in place a ban on making, selling, and transporting liquor in the U.S. It would go on to be repealed nearly 14 years later. But how did the Prohibition movement inform drug policies in our country in later decades? We talk about that with Thomas Pegram, history professor at Loyola University in Maryland, and author of the forthcoming book, Prohibition's Greatest Myths, the distilled truth about America's anti-alcohol crusade. First, you've heard about the opioid epidemic in the United States, but is the country also facing an alcohol epidemic? A new study has found alcohol-related deaths between 1999 and 2017 have more than doubled. The number of men dying from alcohol still outpaces women, but researchers uncovered another surprising statistic when they analyzed death certificates during this time period. To tell us more, joining me now is Aaron White, Senior Scientific Advisor at the National Institute on Alcohol Abuse and Alcoholism. Aaron, welcome to the show.
Oh, well, thank you. My pleasure.
I mentioned that alcohol-related deaths are up over the last decade from 1999 to 2017. But when we think about the rates of alcohol deaths among women, what did you find?
We found that, just as you mentioned perfectly, the overall number of deaths in the United States from alcohol is accounted for by men. Men account for about 75% of the deaths. But the biggest increases over the last 20 years have been among women, which is consistent with increases in drinking among women and increases in emergency department visits for alcohol and hospitalizations for alcohol among women, too.
When we look at the study, it's especially high among white women. What do researchers know about the factors that are leading to this increase in alcohol-related deaths, Aaron?
Well, I mean, that's a question that's yet to be answered. There's lots of speculation. There are probably lots and lots of factors driving it. We know that over the last century or so, since Prohibition, there's been a general narrowing of the differences in alcohol use and negative outcomes among men and women. This has been going on for, at least a century in the United States. So in some ways, this is a continuation of that narrowing that we've been seeing. Certainly, there are other factors. People have speculated that as we're doing our best to march toward equality, we haven't removed some of the typical responsibilities women have held in the society over the last 100 years. So, for instance, there are more women who are breadwinners in their home, but they're still also doing more of the domestic work and taking on a lot of that stress as well. So there's a chance that some of it is driven by increases in stress, increases in the ability to afford alcohol. Some of those factors are probably at play. But my guess is there's a whole list of things that are contributing.
And when we look at some of maybe the social factors, is it more acceptable for women to drink today than past decades?
It certainly seems to be. And in fact, you can see it in the way that we advertise alcohol over the last 100 years. I'm not suggesting the ads are driving the problem, but they do reflect sort of where we are as a culture at that time. And you can see in the advertisements over the last 100 years that ads for alcohol moved from men only to women serving men to men and women drinking together to suddenly in the 70s you see all these ads. It's just women drinking. And so, there certainly does seem to be an increased acceptance of that. And of course, there's a lot of discussion about things like, mommy juice and, afternoon wine, et cetera. We don't know how widespread that really is, but all those things suggest that there has been a cultural shift in how we view alcohol use among women to make it not just more acceptable, but actually more expected among women.
When we talk about advertising, are there particular drinks that people see maybe that aren't as bad as, say, hard liquor? I'm thinking about this craze now for hard seltzer.
Yeah, I think over time there have been these the emergence of types of beverages that are popular for a while. I remember growing up in the 80s and wine coolers were really popular. And so, who knows how long this will stick around, if it'll be a permanent, thing or if it's just a fad. It's the important thing to keep in mind is that the drug is always the same. Alcohol is alcohol. If you're getting a standard serving of alcohol, it doesn't matter if it comes from a beer, a glass of wine, a shot, or a hard seltzer. You're still getting exposed to the same drug in the same amount. The only thing that's going to be different is the other ingredients and the number of calories. But the drug stays the same all the time.
You're hearing on the phone with us Aaron White, Senior Scientific Advisor at the National Institute on Alcohol Abuse and Alcoholism, as we learn about this recent research that looked at death certificates from 1999 to 2017, finding that alcohol-related deaths are on the rise, more than doubled in that time period. Aaron, I wanted to talk more about, physiologically how alcohol impacts women differently from men.
Mm-hmm. Yeah, that's an interesting story that's developed over the last 20 or so years of science, and it's not a finished story yet. I mean, it seems like every year new findings come out to suggest that there are sometimes subtle differences in how alcohol affects women's bodies and men's bodies. Usually, it's in ways that make it less healthy for women, but not all the time. But yeah, for some reason, we really don't understand why. Women seem to be more likely to develop certain harms from alcohol. For instance, once the liver gets inflamed from drinking in women, it progresses to full-blown liver disease faster. The progression of alcohol use to alcohol use disorder seems to happen faster for women. Women seem to be at an increased risk of certainly breast cancer from relatively small amounts of alcohol. For some reason, women tend to have memory blackouts more easily than men. And even if you give alcohol to somebody in an IV, so you can perfectly control how much alcohol they get in their body, women get worse hangovers than men at exactly the same amount of alcohol. So part of it seems to be that women absorb alcohol differently than men, so they end up with a higher peak blood alcohol concentration after each drink. A lot of that just has to do with the fact that women tend to store more fat in their bodies than men. So if a man and a woman of exactly the same size drank a shot, the woman has more body fat. Typically, that means less water in the body. So the alcohol goes into a smaller amount of water, so your blood alcohol level is a little higher. So it could be physiological differences like that drive some of the health differences. But, we're just beginning to really try to unpack it and figure out what's going on.
I'm also wondering if researchers have been able to look at the rate of binge drinking, especially. Is this something that's more prevalent among women? And what are we seeing among young people, Aaron?
Yeah, good question. So somebody looked at data from 6 big national surveys for over the last 20 years and reported that there's been an increase in alcohol use in the United States of about 10% over the last 20 years, but most of that is among women. Men really haven't changed much at all, either in binge drinking or in the number of men who drink. But the number of women who drink and the percentage of those women who engage in binge drinking has gone up precipitously. So that certainly has to be a driver in why we're seeing these increases in harms like deaths and emergency department visits. There are just more women drinking, and of those women who are drinking, more are engaging in binge drinking.
And with young people, what do we know in terms of, has it been going down?
People, we're seeing sort of the opposite pattern with young people. With adults, there's been an increase in consumption that's been bigger for women. Among young people, including young adults, college age, and other people in the workforce, there's actually been a decline in alcohol use. Among teenagers, it's been a big decline. It's been alcohol use and binge drinking have been cut in half over the last 20 years or so. Most of that decline has been for men. So, women aren't really budging as much. And so the gaps have really narrowed there as well. But the good news is it's going down. The bad news is we don't know why it's not going down as much for girls. And there's another part of this story, and that is that we're seeing that our kids aren't socializing as much. And, alcohol tends to be a socially used drug. So they might just have fewer opportunities to drink. Our kids are more depressed and anxious. The data tell us that they're more likely to drink alone when they drink. So it's not all good news. Our concern is that of those kids who are drinking, there might be more who are going to be likely to drink in an unhealthy way to cope with stress, for instance. So there's always different layers to these stories. But regarding, our kids, the good news is drinking has really plummeted. And there does seem to be an interest among younger adults in sobriety, in taking at least a month off. There's sober September and dry January. So it seems that we're seeing the beginnings of a real cultural shift in how young people in our country view their relationship with alcohol, which is very promising.
I mentioned at the top of the show, most Americans are aware of the country's opioid epidemic. But when you compare alcohol-related deaths to opioid overdoses, is it still worse, Aaron?
Oh, yes. I mean, for instance, in this study, just based on death certificates in 2017, there were about 73,000 Americans who died from alcohol-related causes, compared to about 47,600 opioid overdoses. But it's important to recognize that far more Americans drink alcohol than use opioids. So it tells you just how dangerous opioids can be. That one drug that's used by a much smaller portion of the population can cause, that much harm. I mean, alcohol is our most widely used intoxicant, so it makes sense that you'd see more total harm related to alcohol than these other drugs. But the reality is, we don't have a problem in this country with any specific drug per se. We have a problem with people struggling to cope with their lives and losing hope for the future, et cetera. That's what's driving what are being called deaths of despair. And they involve lots of drugs. My guess is that, if there were another drug that was more easily available than alcohol or opioids, that's what people would be using. And so, that's a whole different story. People want to cope with their lives. And if it's difficult, we just have a tendency to reach for substances like alcohol and opioids. But there's not one specific drug that I would say is the problem. The problem is, why people feel compelled to reach for them.
I want to bring into the discussion now Nancy Navarrete, Deputy Commissioner for the Connecticut Department of Mental Health and Addiction Services, or DMAS. Nancy, welcome to the show.
Good morning.
So we've been talking about this research that Aaron and his colleagues did looking at alcohol-related deaths from 1999 to 2017. How does DMAS respond when they see this national study and the findings? Mm-hmm.
Let me just step back a little bit just so your listeners understand the work that we do. We are an agency that serves adults, so we serve adults over the age of 18, and we offer treatment and recovery supports to individuals with addiction and mental health issues. We also do a lot of prevention across the lifespan. Mm-hmm. So that's where some of our work may overlap with the discussion this morning is in our prevention work.
And so when DMAS sees this study come out, what is the response and what do we know about what Connecticut residents are facing?
Well, I agree with Dr. White that basically a drug is a drug is a drug, and our efforts are going to be similar. And we have learned from Connecticut has done a great job in lowering the rate of tobacco use with young people. We've also mimicked the trends nationally that Dr. White spoke of, where drinking has decreased. Mirroring the results that Dr. White mentioned, women or young girls do binge drink more than young boys in Connecticut. Boys start drinking earlier. So boys will start drinking as early as 11. For girls, it's 13 they may start experimenting with alcohol. They quickly catch up, though. So in high school, they're perhaps exceeding what the boys are using. So it's a complex question, and the whys are still up in the air, as Dr. White mentioned.
DMAS helps adults 18 and over. So when we think about people struggling with substance abuse, I guess starting with alcohol, are there enough treatment programs to help people that are struggling with alcohol abuse?
We have over, beds are not, we like to say beds are not always the answer, the inpatient treatment facilities, but we have over 1,000 beds in the system, in the adult system. Now, again, we're serving folks that are low income. may be on Medicaid or unentitled. So it's not the whole population. It's a segment of the population. We have a 1-800 number that will connect people directly to an open bed. We have a public-facing census tool that folks, parents, young people can go on and look and see where across the state there may be services available for them. I think part of what Dr. White alluded to is that young people through the Connecticut School Health Survey are still feeling like they're not getting the help that they need, which may increase their use of substances.
Before we go on to the rest of our show, Aaron White, we talked a little bit about it doesn't matter what type of alcohol you're drinking when we think about the impact on the human body, but some other myths about alcohol that you want to put to rest before we let you go?
Oh, sure. Well, thank you. And I also, I appreciate all of Nancy's comments, and she reminded me that it is the case nationally right now. More girls than boys are drinking by 10th grade and in college for the first time in recorded history, and also young adults not in college. Young women are more likely to drink and binge drink than boys. So we're really seeing a cultural shift here. There are quite a few myths about alcohol that interestingly, some of them I believed myself until I learned the opposite. So, for instance, it's a myth that over in Europe, they've figured it out, and if they just let their kids drink, they don't develop problems, etc. Our teenagers drink less than teenagers throughout Europe. So the solution is not lowering the drinking age or letting our kids drink at home. Also, there's nothing special about wine. Wine is not extra protective for your health or extra boosting for your health. Again, it's just a different delivery system for alcohol. So, and the other thing I would say is hangovers. We get a lot of questions this time of year about how to prevent hangovers, and I hate to tell you, the only way to prevent a hangover is to just not drink too much. Everything else is just treating the symptoms. There's really no way to prevent it or get rid of it other than time and suffering. And those are a couple that come to mind.
And we can't forget to mention that no matter what you think, it doesn't help you sleep better.
Well, that's the other thing, too. It disrupts your sleep. Mm-hmm. It helps people fall asleep a little faster, so they sort of get tricked into thinking it helps sleep. But what it does is then fragments your sleep, and people tend to wake up earlier. And, of course, as we age, that's the last thing we want to be doing.
Well, I want to thank Aaron White, Senior Scientific Advisor at the National Institute on Alcohol Abuse and Alcoholism, for joining us today to talk about this research that he and his colleagues undertook, again, looking at alcohol-related deaths over the last decade from 1999 to 2017. Aaron, we appreciate you coming on. Thank you.
Oh, my pleasure. Thank you so much.
This is Where We Live from Connecticut Public Radio. I'm Lucy Nalpathanchel. Also with me in studio is Nancy Navarrete, a Deputy Commissioner for the Connecticut Department of Mental Health and Addiction Services, or DEMAS. She's going to stick around as we continue to talk about, again, substance abuse in our country, recovery programs, but also we're taking a look back, this next segment, at Prohibition and the impact of that national movement on drug policy. Find us on Facebook and Twitter at Where We Live. This is Where We Live from Connecticut Public Radio. I'm Lucy Nalpathanchel. Earlier, we learned about some of the reasons why the rate of alcohol-related deaths have risen in the U.S. in the last 2 decades. This past January marked 100 years since Prohibition went into effect. How did this national law affect addiction and inform subsequent drug policy in the U.S.? Thomas Pegram, professor of history at Loyola University in Maryland. He's the author of Battling Demon Rum, The Struggle for a Dry America, 1800 to 1933. Also a contributing author to a book about to come out in April called Prohibition's Greatest Myths, The Distilled Truth About America's Anti-Alcohol Crusade. Tom, welcome to our show.
Yeah. Happy to be here.
I mentioned that today is the anniversary of when Prohibition actually went into effect. Give us a little history lesson in terms of when the country prohibited the sale of alcohol, and why did it take a year to implement?
Well, it took actually the national constitutional prohibition was the end point of 100 years of temperance and then prohibition activism, first emphasizing individual self-control, then turning to laws Connecticut itself had a prohibition law in the 1850s, which then went away. The national prohibition movement built out of the progressive era, so there's a reform element, there's a public health element, there's concern about working class families among industrialists, some industrialists. There's a concern about efficiency of workers. Workers used to traditionally drink on the job. Women, middle-class women, are supporters of prohibition, although not all of them are. But it's also a nativist movement and a coercive movement. It's a religious movement. The Anti-Saloon League, which was the major lobbying organization that pushed for a political solution of the liquor problem in the United States, saw itself as the church in action against the saloon from a Protestant viewpoint. So it's a long step. The year lag between the enactment of prohibition and its implementation was really to allow the liquor industry a year to conclude its business, to get a little lead time into the enforcement.
So in terms of the implementation, that was the Volstead Act in 1920?
Right. The Volstead Act, there are two different parts. The 18th Amendment is pretty general in its approach, eliminating the manufacture, transportation for sale, selling, or importation of intoxicating liquor, but it didn't define what was intoxicating. The Volstead Act did that, and it actually took a lot of people by surprise. Brewers thought that prohibition was for whiskey. They considered their drink to be a healthy drink, and at the very worst, they thought that maybe 3% beer, which was what you had during World War I when there was a restriction on cereals, that would be the national standard. Instead, the Volstead Act adopted a very harsh 0.05% alcohol content made for an intoxicating liquor. That was a tax standard. It wasn't one based on science, but it essentially eliminated all alcoholic beverages.
And so before the Volstead Act, there were already plenty of places in this country that had actually banned drinking because of the temperance movement and others?
Yeah. Much of the country was under state prohibition laws. One reason they pushed for national prohibition was the Northeast was holding out, and in order to keep alcohol out of dry states, they went for that. But there actually a lot of the emphasis was at removing the supply and attacking the liquor industry, either saloons or distillers. They were the target more than individual drinkers. A lot of states that had state prohibition laws had personal use exemptions. You could import up to a quart a month, in some cases, pretty large amounts of alcohol for personal use. That all disappeared with national prohibition and the Volstead Act.
Tom, I was wondering if you could go more into detail, again, before prohibition was passed, how serious of an issue was alcoholism in the United States in terms of consumption?
It was a massive issue. Especially in the 19th century. In the 19th century, when the United States was industrializing, first of all, there are no safe liquids to drink. Water supplies aren't really safe. Milk can't be kept fresh. Distilled liquor was really the safest thing to drink. And that meant Americans drank an awful lot. That's why you first had these temperance movements in the 19th century. Going into the 20th century, alcohol consumption became tied into a cultural war as more and more immigration from Eastern and Southern Europe, wine-drinking countries, distilled liquor drinking countries, countries with the tradition of the Continental Sunday, where you would go to a beer garden with your family on the weekend rather than spending the day at church or in contemplation. That tied into it. There are automobiles. There's moving machinery. There are a lot of issues that made drinking a big problem.
You're hearing Tom Pegram, again, professor of history at Loyola University in Maryland, author of a couple of books, one forthcoming called Prohibition's Greatest Myth, The Distilled Truth About America's Anti-Alcohol Crusade. I wanted to ask, since we heard about the lead-up to Prohibition, Tom, once it was implemented, talk a little bit about its impact, short-term and long-term.
Okay. Short-term impact was there was an attempt by the country, by and large, to accept the law, but over time there was greater and greater resistance. It was a big step to defy a constitutional amendment. Connecticut, for instance, none of the representatives from Connecticut voted to pass the Prohibition Amendment. Connecticut didn't ratify the 18th Amendment, but once it became law by 1921, Connecticut passed what was called by the Anti-Saloon League a fair enforcement law. So there were attempts to enforce. The problem was there wasn't a real mechanism to make enforcement effective and corruption-free, partly because there was a split between a vision of federal enforcement that could be done on the cheap, claimed the Anti-Saloon League, and state enforcement. This is the concurrent enforcement component of the 18th Amendment, which meant you had to have states and federal officials working hand in hand. There was never a big enough budget to enforce the law everywhere, and many states made minimal attempts to enforce. Some did, but over time, beginning with New York in 1924, some states began to repeal their enforcement statutes, saying that the law was leading to a kind of defiance of law and a kind of moral degradation because the law could not be enforced. So there was some enforcement. Unfortunately, the harshest enforcement was against marginal groups in 1920s society, immigrants, African-American communities. Prohibition was real for some Americans. They really did feel the brunt of it. In other cases, if you were wealthy enough, first of all, you could, if you had legally purchased pre-Prohibition alcohol, you could drink it in your home, and you could serve bona fide guests. You couldn't sell it. You couldn't move it around. But so there were class dimensions to the reform that also led to controversy.
You mentioned that Prohibition disproportionately impacted immigrants and people of color. Can you talk more about that? I understand the KKK was even involved in this movement.
Yes, the Klan was actively involved in Prohibition enforcement in some places. The Klan in the 1920s was a mass movement. It was one that claimed that native-born white Protestant Americans were the authentic Americans, and they somehow had some genetic predisposition for democracy that other people did not have. And so immigrants, Catholics, non-whites aroused suspicion in their eyes. Those were also the groups that were most suspicious and skeptical toward Prohibition. And what happened in some communities is that members of the Klan arguing that if the law is not being enforced, that leads to a drop in the effectiveness of democracy. They essentially volunteered to act as constables in Prohibition enforcement for cash-strapped state and local authorities. In Indiana, there was an old anti-horse thief law that allowed private citizens to be deputized, and hundreds of Klansmen across the state were deputized under the Horse Thief Detective Association. Some of them were issued firearms, badges, and they went out and took part in Prohibition raids.
And this also, Prohibition started this incarceration, more prisons that were developed?
Yeah, that's a major development out of the Prohibition era. There's so many arrests under the prohibition laws, which get stronger over time. In 1928, 1929, when Hoover comes in as president, there's actually a renewed attempt to enforce the law, and there are harsher incarceration laws, and a lot of national prisons are built during this period. There's also a rise in crime in the early part of the 1920s. It's not totally tied to Prohibition. It begins to dip again after 1925, but that led to an after-the-fact reaction and the building of more prisons. And it also kind of enshrined a coercive, punitive approach to regulation rather than one that emphasized education. And that had been a split in the Anti-Saloon League. There was one branch that said, we don't care about the next election, we care about the next generation. People should learn not to depend on alcohol, and we should help them to learn that. There were others that wanted quick results and wanted to rely on the law and on harsh laws. And that side tended to win out.
Eventually, Prohibition was repealed nearly 14 years later. When we look at policies in our country in the subsequent decades after, in terms of the war on drugs, was this public policy approach, was it influenced by the Prohibition movement, Tom?
Yes, although with some differences. One of the big differences was the alcohol industry, liquor manufacturers, were dead set against Prohibition. But some of the important drug laws and enforcement was actually supported by pharmaceutical companies and others who manufactured some legal drugs, and they wanted to maintain control over them. But in other ways, one of the branches of the Prohibition Unit, which was the federal enforcement arm, did narcotic enforcement. Another thing that they shared was that marginalized communities and working class communities tended to be targeted more fiercely. A lot of opiates originally were used by middle class Americans, prescribed by doctors, just like middle class women drank alcohol unknowingly and with various health potions like Lydia Pinkham's vegetable compound, which contained an enormous amount of alcohol. It's only when use started to spread to the streets, to immigrant communities, there's no concern about marijuana until Mexican immigrants are coming into the United States in the Southwest, and they're concerned. There's the cocaine panic in the 19-teens and 1920s. So you start to get drug regulation about the same time. After Prohibition falls apart, a lot of the same personnel go into drug enforcement, and the model is the punitive, coercive one, using law and punishment rather than one that emphasizes education and an attempt to lower demand.
You mentioned how Prohibition, once implemented, impacted immigrants and people of color. Years later, in the 70s and 80s, seeing policy come out that disproportionately impacted people of color and mass incarceration rates as well. Yes,
I think there's a clear connection. I don't think a lot of these advocates of Prohibition really envisioned that. But the nature of the reform and the problems of enforcement that it encountered in the context of American culture, politics, and American prejudices allowed that to happen. It's much more intentional, I think, in the war on drugs.
You've been hearing Tom Pegram, professor of history at Loyola University in Maryland. In studio with me is Nancy Navarrete, Deputy Commissioner for the Connecticut Department of Mental Health and Addiction Services. Nancy, we're hearing about the punitive approach that was accepted, especially after Prohibition. I'm just wondering if you can talk about how public policy is changing now, specifically in Connecticut, where there's a lot of emphasis now on second chances and decriminalizing certain amounts of marijuana because of the ripple effects of certain people that were definitely impacted much greater than others because of these policies.
But certainly some of the lessons learned are that the punitive methods, law enforcement, we can't arrest our way out of this problem. It is not something we can arrest our way out of. There isn't the type of treatment necessarily available to people that are involved in criminal justice system, and we want to do whatever we can to strengthen engagement. So no matter where somebody is on the continuum, we can bring them into our system and get them the kind of help that they need. So there's been a lot of effort in jail diversion, re-entry, connection of people leaving the criminal justice system to our community services.
I mentioned the opioid epidemic. We've seen policymakers look at this as a medical, or trying to treat addiction as a medical problem, not a moral one. But the stigma still exists. People think that with the flip of a switch, that people can just stop taking or abusing these drugs, and it's not that easy.
It is not that easy. It's very complex, and there are different paths to recovery for different people. For some people, medication is helpful depending on the drug that they're using or misusing. For other people, self-help is extremely effective. Outpatient therapies, auricular acupuncture, whole person therapies, alternative therapies. So there's an array of services, inpatient and outpatient, out there for people.
Some would argue that all drugs in the country should be legalized, but we know alcohol is legal over 21. It's still a growing cause of death in this country. So how should this issue be approached, overall, in terms of making sure that people, if they're struggling with substance abuse, that they can get help?
Well, one thing I would say is that the longer that we can delay a young person from using substances, the less likely they are to develop an addiction disorder. So, for example, if a young person starts drinking before the age of 15, they're 6 times more likely to develop alcohol dependence or misuse later in life than those who begin drinking after 21.
I'm probably asking you this too late in the conversation, but I'm going to throw it in anyway. Now with the marijuana legalization conversation happening, how does that complicate efforts to postpone use among young people and others?
I think we have to do our job in terms of prevention. We can apply some of the same public health principles that we have successfully applied to alcohol use in teens and smoking in teens. Connecticut's rate of smoking in teens is well below the national average. Adults actually in Connecticut smoke less than the national average as well. We have done such a good job with prevention in that area, and I imagine we would need to continue those efforts.
We're going to head to break. I want to thank Tom Pegram for joining us again, professor of history at Loyola University and contributing author to this forthcoming book, Prohibition's Greatest Myths, The Distilled Truth About America's Anti-Alcohol Crusade. That book coming out in April. Tom, thanks for joining us today.
Oh, thank you. Good conversation.
Thank you. And Nancy's going to stay with us again. Nancy Navarrete, Deputy Commissioner for the Connecticut Department of Mental Health and Addiction Services. We're going to expand this conversation about recovery programs in the state of Connecticut. We're going to hear about the growing number of hospitals using what's called recovery coaches. You can join us too. Find us on Facebook and Twitter at Where We Live. This is Where We Live from Connecticut Public Radio. I'm Lucy Nalpathanchel. Now, Where We Live has talked about the importance of recovery coaches. Several months ago, we focused on the city of New London, which has partnered with first responders there to help connect residents to substance abuse treatment programs. Now, recovery coaches also are working out of emergency departments in the state. Connecticut Public Radio's Nicole Leonard has reported on efforts by the nonprofit Connecticut Community for Addiction Recovery. Nicole joins us now in studio. Thanks for coming back on the show, Nicole.
Yeah, I'm happy to be here.
So tell us about recovery coaches. Why are they growing and why are they being placed in hospitals?
Yeah, recovery coaches, they're not meant to duplicate services that are provided by doctors or psychologists or physicians. They really are there to help support people who are struggling, sometimes in the most traumatic points of their active addiction. The particular recovery coaches that we focused on recently are ones that work in emergency departments. So they may be seeing people who are coming in with after an overdose. They may be seeing people who just went to the hospital because they recognize they have a substance use disorder, but they don't know where to go for help. So these people are really there to help support that person, their family members, and help explain to them maybe what the medical personnel is telling them, as well as connect them with some of the addiction prevention or treatment services in the community. So they're really an important link that are working with other medical staff in the emergency departments to help support people who are struggling with addictions to drugs or alcohol or other things.
You met a resident, I believe her name is Deb Truax, who is one of the residents that's been paired up with a recovery coach. Can you tell us a little bit about her?
Yeah, Deb. Deb was, she recognized that she was struggling with a substance use disorder, and it wasn't opioids. So a lot of, even though there's a lot of focus on the opioid epidemic, there are still people, as we know through this entire segment, that, people are still struggling with alcohol and other drugs. So she recognized she had a problem, but she was afraid to tell family and friends. She really didn't tell anybody about it. And so she went to a hospital for help, and that's when she got connected to a recovery coach.
You alluded to her. She didn't want her family to know about her trying to get help for addiction. Let's hear what she told you.
Because the stigma is so powerful, because that's why we stay hidden and we don't get help, and it gets worse and worse. Wherever we find that is a gift, and it's helpful. And so a whole profession, a whole position devoted to that can do a great deal of good.
You also talked with Michael Serrano, who was her recovery coach. Talk about why that was such a powerful partnership, because when we talk about stigma, he knew exactly what she was going through.
Yeah, a lot of the unique thing about recovery coaches is that if most of them are in recovery themselves. So they've directly experienced substance use disorder. They are in recovery, which is a lifelong thing. You're always in recovery and you're always working toward recovery. So Michael was able to connect with Deb in a way that she didn't feel she was able to connect with maybe doctors and other medical personnel that were trying to help her. They were doing their jobs. But it was really when she met Michael that she said, okay, here's somebody who actually understands what I'm going through, who won't judge me, and he was there to help her navigate this very scary time in her life.
And how long do these recovery coaches work with individuals?
So a lot of them, they meet with patients in the emergency department. That's really their first point of contact. And sometimes people right out of the emergency department, they can help connect them directly with maybe that person wants to go straight into detox. Maybe that person wants to go into outpatient treatment. Sometimes, though, it's really just connecting, making sure they have their contact information, and then the recovery coaches follow up with that patient the next day, the day after that. They'll call them every day sometimes to help keep that connection. And so sometimes they will stay in connection with these patients for long periods of time. And Michael and Deb met back in 2018, and they are still connected, and they're both in recovery.
Wow. Nancy Navarrete is with us, Deputy Commissioner for the Connecticut Department of Mental Health and Addiction Services. I understand that this Recovery Coach program is one of the initiatives from DMIS. Can you talk more about, how many recovery coaches there are in Connecticut and, some of the outcomes you've been seeing?
Well, right now there are recovery coaches in 19 hospitals across the state, which is very significant. We have recovery coaches in many levels of care. So in our methadone clinics, we have recovery coaches. We have recovery coaches that are women, so they can establish a unique connection with our women pregnant and parenting who are in recovery. That's a special population. And it's just really helpful to be able to look someone in the eye that has been through the same thing or a similar experience as you have. And I think it's just a comforting, and you had used the word partnership. It's a partnership and a relationship that can really help a person find their path.
I wanted to take a quick call. Keith has a question. Keith, go ahead.
Hi, thank you for taking my call. So my question is for the panel. I have a friend who's struggling with alcohol addiction, and he's in his early 20s. And I've been trying to help him provide like a mental support and like support group through friends, but he's really struggling. He had like 2 DUIs, and we're just all like really worried. So if a panel can suggest any resource or anything like that, that would be helpful. Thank you.
Nancy?
Sure. So our website, if you look for Connecticut DEMIS, there are many resources there. We have a 1-800 number, so 1-800-563-4086, and we would be very happy to connect you with services through our 1-800 number. We also have a Live Loud campaign, and through that campaign, it's targeted on opioids, but it will link you to some of the services in our system.
And just to clarify for Keith, who's calling, if they want to look at the website, what is it? ct.gov/?
Yes, if you just put in your browser Connecticut DEMIS, you will be taken right to it.
And DEMIS is spelled DMHAS for Keith.
Correct.
Okay. Before we run out of time, I understand that there's efforts to expand this recovery coach program, also to help people in the Department of Corrections. I wanted to highlight this report from Connecticut Mirror's Kellen Lyons, who found that former inmates now account for more than half of all drug overdose deaths in Connecticut. So how soon will that be helping people out of prison, Nancy?
So it's really important. As you said, that's a statistic that is quite frightening. What happens is people establish some time without substances in their system when they're incarcerated, and then upon release, they are not connected. They may not be connected to services, and that is a key interval. So if we have these recovery coaches connect people directly from discharge to the next level of care. So a community provider, be it a physician or a counselor or a person in recovery, then I think we're going to start seeing success and turn those numbers around. So that will be up and running soon.
And so the funding for this program out of DEMIS, your department, not in jeopardy when we think about the next legislative session and budget cuts? So
these are federal dollars, okay. And they go through September of this year, and we are hoping that we will get another year, a third year of what's called SOAR, State Opiate Response dollars, and it's looking good that will happen.
Well, I want to thank again Nancy Navarrete for joining us, Deputy Commissioner for the Connecticut Department of Mental Health and Addiction Services, or DEMIS. DMHAS is the acronym. Nancy, thanks for joining us today.
Thank you so much. Thank you for having this conversation.
Also with us, Nicole Leonard, Connecticut Public Radio's healthcare reporter. Nicole, we're going to link to your story at WNPR.org/where we live. Also tweet it out at Where We Live. We thank you for coming in.
Thanks for having me.
Today's show produced by Carmen Baskoff. Our technical producer is Kyone Wolf. Learn more about the show. Just download Where We Live on your favorite podcast app. And if you like us, give us a review. I'm Lucy Nalpathanchel. As always, thanks for listening. Have a great weekend.